Guys, I'm feeling a bit old these days. This month is going to be my 35th year as a paramedic. I graduated from Houston Community College and started as a paramedic for Williamson County EMS in December of 1988. How long ago was that? Well, there were some treatments that we knew were standard of care. Anti-shock trousers and high-volume crystalloid resuscitation and trauma. Escalating doses of epinephrine, calcium chloride, continuous compressions, mechanical compression devices with the old school thumper. Those are the ones in cardiac arrest. And backboards for, well, everything. Hyperventilation for TBIs, steroids for spinal cord injuries. Now, these sound outdated and maybe just odd now, don't they? At least some of them do. When was the last time y'all pumped up some MAST pants or gave some Solumedrol in massive doses for spinal injuries? So what do all of these things have in common? Well, they're interventions that seemed like they should work. They had great theoretical reasons for why they should work. And they even had some studies, maybe some in animals, maybe some human observational studies saying they worked. Now, some, and I'm looking at you, MAST trousers, had really good marketing. And that was enough to make them standard of care. Everybody adopted them, even if some of this stuff was very expensive. Even if we had to devote a lot of training time on them. Even if all that attention distracted us from other things that we knew worked. Like, say, high-quality pit crew resuscitation. And I'm looking at you, mechanical compression devices. Oh, by the way, there's something else they all have in common. High-quality evidence that was done after these things were prematurely adopted that showed these expensive and distracting interventions did not work. Which brings me to Head Up CPR. So I've been rather tied up lately reading about how Head Up CPR is the standard of care and should be put on every fire engine in the country. That's why I haven't released an episode in a while. Okay, so finally getting the Airway EBG paper published that may have had something to do with it too. It's out. Go take a look. I'm really glad it's done. But go take a look. A lot of people put hard work into it. Stick around, guys, this Head Up CPR thing. Stick around and we'll review the evidence behind it. And I'll explain why I don't think it's ready for prime time yet.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we bring the bright light of science to the darkness of modern EMS clinical practice. I want to talk Head Up CPR. Now, I first learned about this resuscitation strategy, this bundle, at a conference last year. I heard miraculous things about it. There were even some emotional survivor cases, very impressive survivor cases. I heard about the animal studies explaining why it should work. And I heard about some observational studies. What I didn't hear about, though, was convincing clinical evidence that it worked any better than cheap, well-organized, and well-choreographed resuscitation. My takeaway was this sounded like a promising technique, but honestly, I kind of felt like I'd sat through a sales pitch for a cool new car. Now, a cool new car that, although it was expensive, I really wanted to fall in love with. It was, what's the best way to say this? Sexy. but man, it was expensive and it would take a lot of training to implement it. And it would require us to alter our approach to arrest resuscitation, like a lot. Would need to add ITDs, would need to add an Eligard. And that's the new device that attaches to a Lucas, which, by the way, we would need to buy a lot of. After a few minutes of supine CPR, that thing will gradually elevate the head and thorax. And the manufacturer makes some compelling reasons about why it should be gradually elevated. Okay, get that. So I was left with a choice to make. Should I ask my agencies to spend a lot of money and training time for this shiny new thing? Now, I have a formula I use for helping me make these types of decisions. I'd like to propose that it could be useful for other medical directors and agency directors when they need to evaluate whether the evidence for something is sufficient to adopt it. So here's my formula. The level of evidence needed to adopt a thing is proportional to the cost and risk of the thing. I didn't say it was a complex formula. Let's talk about the components of it, shall we? So, evidence. There's a hierarchy of the quality of evidence that goes from animal studies to human case reports and case studies to observational studies like cohort or case control studies to placebo-controlled randomized trials, all the way up to meta-analyses of multiple well-done placebo-controlled randomized trials. Each one of these levels provides additional evidence that the effect they find is due to the intervention being studied and not some unknown thing. All right, that's evidence. Cost? Well, that's a function not just of the price of the shiny thing, but of the price of the training, the maintenance, and implementation of the shiny thing. Now, risk, that's the obvious. The intervention may cause direct harm to patients. But it's also the risk of lost opportunity cost, time spent training on something of less or no value instead of on something of known or higher value. And finally, there's distraction risk. Adopting the new thing risks distracting clinicians and systems from doing the things that they've been doing. This is especially harmful when the things they've been doing work. Now, my friend Luis Gonzalez and the folks at Austin Travis County EMS published a great example of this a few years back. They had a well-choreographed system of pit crew CPR with impressive survival rates. And then they adopted the Lucas. They did it in a way that created a nice experiment between patients who had the Lucas and those who didn't, because of the way they implemented on some engines that moved around the county. They would have an even distribution of those who got the Lucas and those who didn't, having nothing to do with decision-making about that patient. Now, even after spending a lot of time training on how to rapidly apply the Lucas, survival ended up being lower in those patients who got the Lucas than those who only had manual CPR. Implementing a new thing in the face of good evidence showing no benefit, which is what we had for the Lucas, turns out it actually led to harm. And that's what I mean by the risk of distraction. So here are a couple of examples of how I would use this adoption formula. Adding a new indication for a drug we already carry for something else, a drug that has been used extensively and has a good safety profile. This has no additional cost and very low risk. As a result, I'll still need some evidence that it works for the new indication, but it doesn't have to be multiple placebo-controlled randomized controlled trials. A few observational studies might do the trick. Adding droperidol for cannabinoid hyperemesis and migraines when I already carried it for agitation and nausea, that's a good example of this. And now on the other extreme, let's say we want to adopt a new intervention that we don't currently use. Let's just say it costs a lot of money and might cause patient harm. Let's further say it'll require a lot of training time and it will probably distract us from existing priorities. For me to justify adopting this intervention, I need a very high level of evidence. One, maybe two RCTs that are well done in populations similar to the one we'll be treating. Now, let's apply this formula to adopting Head Up CPR. We know it's expensive. We know it'll need lots of training to deploy, and there may be risks. Risk of distraction from other things. And here's one. Is there a risk of lower cerebral circulation because we raise the head up? Sort of like we don't sit up hypotensive bleeding patients. Well, that's a possible risk, but fortunately, that's one of the things we do animal studies for. We do need some evidence here that that risk is low, and we have some. There are 5 or 6 studies in pigs that, for the most part, with one exception, show that cerebral perfusion pressure improves when raising the head and thorax during CPR, at least in pigs. Overall, the animal evidence suggests there is potential benefit, but limited harm, and that's good. And again, I mentioned that one conflicting study. That was the most recent one that came out, and it suggested perhaps the animal studies were measuring pressures wrong. I'm not an expert there. I'm going to let that settle out for a little bit. But overall, I think they probably demonstrated not a lot of harm. Now, what about cost? There's a lot of it. Head Up CPR is a bundle that includes a Lucas 3, an ITD, and an Eligard, plus or minus a rescue pump that manually creates active decompression. The Lucas 3 sort of creates active decompression. Now, these things are all proprietary, and they ain't free. They're being proposed for every first response unit in the country. So that's a pretty expensive deployment. So sounds like we need some high-level evidence. And to date, there are only 3 observational trials. That's it. That's all we have. The first of these was a before and after study. It showed improved ROSC, not survival, but ROSC, with a manual elevation using a longboard and pelican case. They just propped the longboard up on a pelican case. It was really designed as a feasibility study, which is why I'm not going to ding it for only looking at ROSC. And it showed the intervention could be done safely, and might have benefit. Now, the 2 studies left out of the 3 both involved the same 227 patients who all got Head Up CPR. These patients were enrolled in a manufacturer-supported registry where agencies who had adopted that Eligard bundle entered their data into a database, again, manufactured by or maintained by the manufacturer of the Eligard and the ITD. Now, interestingly, there were actually 409 patients enrolled by 10 agencies, but only 227 were analyzed from 6 agencies. For some reason, 4 agencies were excluded because of what the paper said was they didn't have routine and consistent recording of time to placement of the device. Now, I say some reason. I'm confused about this. I'm a little skeptical about it. The reason this wasn't clear in the papers is because the declared outcomes didn't involve time to placement, at least for the second paper. And that second paper is the one with the best evidence for adoption, the one with survival benefit, or claimed survival benefit anyway. So if you're selecting only 40% or excluding 40% of your agencies, it raises some concern for selection bias. And what I mean by that is maybe those patients that were included are somehow different than those who are excluded. Now, this does not imply an intentional exclusion to make the device look better. I want to be clear about that. They may have had a good reason for excluding them, but there may have been something about those excluded patients that would have changed the study's outcome if they'd been included. More on that in a bit. Now, the first of these 2 studies had no controls and just showed improved ROSC when treatment with the bundle was initiated sooner compared with later. Now, for this study, it does make sense to only focus on those with time to implementation. This paper is limited by time or resuscitation bias, though. Now, in other words, time to any treatment in cardiac arrest is important. Maybe it was the time to first CPR that made the difference and not the time to the head up thing. We don't know because there were no controls. Every patient got the full meal deal. The next paper is the best human evidence for head up CPR, so I want to dig into it a bit more. This paper was by Moore and her colleagues, and it was titled Head and Thorax Elevation During Cardiopulmonary Resuscitation Using Circulatory Adjuncts is Associated with Improved Survival. It was published in July of 2022, and yes, I intentionally stressed the claim of benefit in the trial, improved survival. We'll come back to that in a bit. This was an observational study that compared those 227 patients from the manufacturer registry to 3 different, distinct, not the same, study groups that they combined into a single data set. They used propensity matching to attempt to control for baseline differences between groups. So, propensity matching. Basically, it takes one of the case patients and matches that patient to a control patient with similar characteristics that are known to impact survival. These are things like age, sex, response time, witnessed status, and the initial rhythm. Was it shockable or was it not? Propensity matching is helpful to match patients getting different treatments from a data set that was collected at the same time in the same fashion from the same population and collected for the same reason. Really, it's designed to take a single population of patients who were treated with different interventions and control for the known differences between patients with different treatments. It is not, however, intended to be used on patients from 2 different data sets. This is because the 2 data sets were sampled from different populations of patients. They are highly likely to be different for reasons other than the known variables that are being controlled for. So those are the methods. Let's dig into the PICO question from this paper. Population. The population studied was of adults with non-traumatic cardiac arrest. The intervention. These were patients in the Head Up CPR group who were treated with the full bundle of care. All of these patients were enrolled in the registry in 2019 and 2020 by the 6 included agencies. The control patients. These were from one of 3 randomized controlled studies with publicly available research datasets. These were rock primed, ALPS, and the rescue trial. Patients were enrolled between 2005 and 2009 in 2 of the studies, in 2012 to 2015 in the last study, the rescue trial. Rock primed compared the ITD to a sham ITD as well as early versus delayed rhythm analysis. This is where they're testing the thing of priming the pump of defibrillation with 2 minutes of CPR. The rescue trial, it looked at the ITD plus a manual active compression decompression device. This was the rescue pod, the ITD, plus the rescue pump, which was the manual active decompression compression device. And they compared that to standard CPR. Now, the last trial was the ALPS trial. It enrolled only patients with shockable rhythms, and then it randomized them to either amiodarone, lidocaine, or placebo. We've talked about that paper before. The outcome, and this is important, the outcome was survival to hospital discharge. The primary outcome was survival to hospital discharge. Secondary outcomes, ROSC and functional survival. The study was built around looking for differences in survival and ROSC. Now, the paper briefly describes those patients who were excluded from the analysis in the intervention registry. It says they were younger, they were more frequently male, and they had less bystander CPR than those that were included. What they don't say, however, is what the overall benefits would have been had they included these patients, and if it would have been different than those that they excluded. Remember, the primary and secondary outcomes in this paper were not dependent on time to placement. It was just survival. Not having that full data, it just doesn't make sense to me as the reason or a reason to exclude them from the primary analysis. Now, there were 227 Head Up CPR patients, and they compared those with 5,196 patients from the combined historical trials. Before propensity matching, in other words, in the unadjusted population, patients in the Head Up group had lower survival than those in the control group. After propensity matching, there was also no difference in survival to discharge or ROSC or functional survival. Let's look at the numbers. The adjusted odds ratio for survival was 1.44 with a 95% confidence interval from 0.86 to 2.44. For ROSC, it was 1.022 with an interval from 0.75 to 1.49. And for functional survival, odds ratio adjusted was 1.47 with the confidence interval from 0.76 to 2.82. Now remember, an odds ratio of 1 means there is no difference. So if the 95% confidence interval includes 1, crosses 1, there's no significant difference. And all three of those crossed 1. So let's summarize here. The primary outcome was survival to discharge, and there was no difference. The secondary outcomes were ROSC, no difference, and functional neurologic survival, also no difference. Let's go back and review the title of this paper again, shall we? Quote, head and thorax elevation during cardiopulmonary resuscitation using circulatory adjuncts, and here's the important part, is associated with improved survival. Right there in the title, the thing that many people don't get past. Right there in the abstract, the thing many people don't get past. Right there in the conclusion, the thing that many people don't get past. So, improved survival, their primary outcomes showed no difference. The secondary outcomes showed no difference. So how do they get away with claiming improved survival right there in the title? Well, my answer is they shouldn't have. If I were a peer reviewer of this paper, I would have recommended to the editor, they don't publish this paper. They don't accept it without changes. What kind of changes? I think it would have worked if they'd changed the title and their conclusion and say this was a negative trial with some promising hypotheses developed. Had they said that, had they not leaned into these exploratory analysis findings, I think it would have been a perfectly reasonable paper. I think they got overexcited and overzealous, and I think the peer reviewers let us down on this. All right, what do I mean by promising hypotheses? Well, you see, they did an exploratory analysis, and they did say they were going to do this up ahead of time, to see if the time to deployment made a difference. After looking at time to deployment in several different ways, they found that patients who received it in less than 10 minutes had higher rates of survival than those who received it in more than 10 minutes. They also found higher survival among patients who had deployment times between 7 and 18 minutes, but not less than 7 or more than 18. Now, there are some statistical reasons, like small sample sizes, why you might not expect to see a benefit under 7 minutes. And there are some reasons, like maybe nothing will work if you deploy something after 18 minutes. I get that. It makes sense. It seems like it should work, but that wasn't your primary analysis. That was an exploratory analysis. It's just what they found after they looked for it. And that's to be expected when you're trying to find a benefit. That's why it's called exploratory analysis. It's perfectly appropriate to do this when you're generating hypotheses to test in future studies. For example, it would have been very appropriate for them to find survival benefit when applied in under 10 minutes. They would then test that hypothesis in a future study with different patients, and that's important, different patient set, to try to confirm this benefit. But that's not what they did. What they did is charitably called overfitting. They claimed an overall benefit of improved survival in the title. They focused on the exploratory results that showed benefit instead of the primary and secondary outcomes, the one the paper's supposed to be about, that did not show benefits. I'm obviously disturbed that they did this, and I'm not the only one. I'm just the charitable one. Dr. Anand Swaminathan on Rebel EM said this conclusion was, quote, frankly misleading, unquote. He calls the use of exploratory analysis to claim benefit by its more pejorative term, data dredging. And I want to be clear that you see, I did not use that term. I'm reporting what Dr. Swaminathan said. He also was an author on a Journal Club article in Annals of Emergency Medicine that dug a little deeper into why data dredging is not appropriate for your primary outcomes. So, I think that about covers the whole claim a benefit where none was shown thing. I've already discussed my concerns with using propensity matching across two distinct data sets. I don't think it is an appropriate use of this otherwise useful methodology. There are just too many unknown and unknowable variables that we can't control for because we don't know what they are. To be blunt, this is why we do randomized controlled trials. I also raised my concern earlier about the exclusion of 40% of agencies submitting data to the Head Up CPR registry. Presumably, they excluded those agencies because they didn't have good data to collect the time to device deployment. But this wasn't needed to calculate either the primary or secondary outcomes in this study. I'm repeating this because I think it's important. They could have used the entire registry for the primary and secondary analysis, and then excluded those missing times for the exploratory analysis that you shouldn't hang your hat on in the conclusion. Now, finally, I have to mention that the studies, including the animal studies, were done by either the manufacturer of the proprietary devices or by the CMO of the manufacturer. Also, the registry was supported by the manufacturer. This raises an obvious conflict and risk of bias. I want to be clear here that I don't think any of these authors intentionally lied or were otherwise dishonest or deceitful. I don't believe that, and I don't want to imply it. I think I give them the benefit of the doubt, and I know some of these people, and I think they're honorable people with honorable intentions. But in science, the authors have to disclose those conflicts, which, to be clear, they have always done. But readers have a responsibility to question whether those conflicts impacted the results, and that's what I'm doing here. Now, speaking of conflicts, financial interests are not the only type of conflicts out there. You can also have intellectual conflicts. This is where you have an intellectual reason to say that the thing works or even doesn't work. Now, some may feel I have an intellectual conflict here, so I want to declare it. I want to be clear about it right up front. I'm skeptical of this bundle. Why? Well, to be honest, I'm skeptical primarily because of the way the intervention has been aggressively marketed, because of arguments by some of its proponents that we no longer even need randomized controlled trials because propensity matching makes them irrelevant, and because of the limitations and potential biases in the study that I just described. So where does my conflict come in? Well, I wrote an editorial for EMS1.com where I raised some of the issues with this trial, and my conclusion there was it was not ready for widespread adoption yet. My conclusion hasn't changed, by the way. Now, I was also an author of an editorial that my co-authors and I submitted for peer review and publication expressing these concerns. It's under review right now as I record this. If it's been accepted and available by the time I get this episode out, I will definitely include a link in the show notes. Now, the last thing I should declare is that I have visited Dr. Laurie's lab several years ago where the animal research here was conducted. Zoll kindly paid my expenses for that visit. To be clear, I was impressed. I'm still impressed by the lab. I'm impressed by their attention to detail. I'm impressed by their passion to improve care. And I understand the physiological theory of why this should work. I really do. It makes sense to me. I just need evidence that it does in humans, and I haven't seen it yet. I've also always been impressed with Dr. Laurie as a scientist, and he's always been kind to me. I like him. Furthermore, here, I'm friends with several of the authors of this paper. I'm good friends with some of them, very good friends with some of them, and I respect all of them. So you may have noticed that this paper was published in July and it's now December. Happy holidays, Merry Christmas, Happy Hanukkah, by the way. I hope you're digging my Whataburger Christmas tree back there. I'm getting into the spirit. So July to December, what took me so long? Well, I was immediately distressed when I read the paper, but I wasn't going to write anything about it. I wasn't going to do a podcast about it. I really probably wasn't going to say anything in public about it, largely because I have a hyperactive loyalty gland and I didn't want to criticize my friend's work. I eventually got around to mentioning this hesitation to Rimley and Peter Antebi. They're both authors on this paper, and they both told me, and I'm paraphrasing here, "Jeff, you're an idiot." They reminded me something I really should have known, but needed reminding of. Science depends on honest criticism. They both encouraged me to do this episode, and I want to thank them for that. Science does need honest and thorough criticism, and I want to be clear, that's my focus here. So I want to wrap up by saying where I think we should and should not go from here. I've heard some of my colleagues say that any use of this device outside of IRB-approved randomized controlled studies is frankly unethical, and some have suggested immoral. I want to be clear, I disagree with this, and I've pushed back on it. Several agencies I know and respect have adopted this bundle, and they're seeing improvements with it. My problem is I don't know if the improvements are because of the bundle or something else, like maybe the Hawthorne effect, for example. But I don't think what they're doing is unethical. I think they have made honest evaluations of the evidence and feel it is in the best interest of their communities to adopt it. I do not, however, think it is anywhere near a proven technology that anyone, any organization can honestly recommend as a standard of care that should be widely adopted, certainly not by every agency in the nation. Again, I'm impressed by the physiologic support for this bundle, for the theory and the rationale for the bundle. I truly, truly hope it really does work. But I recognize that while it may work, it just as easily may not work. I'm still troubled by the rapid adoption of mechanical compression devices, Lucas devices, in the presence of evidence showing no benefit in multiple randomized trials and meta-analyses. Not only multiple meta-analyses, the last one actually said this is an answered question. MCDs do not improve survival. Stop running randomized controlled trials. We have the answer. Now, I want to be clear about this because I know people are going to yell and scream at me. I think the MCD horse has left the evidence-based barn. And I also think there is a use for it. If you're going to transport patients with ongoing CPR, let's just say, then yes, I absolutely want a Lucas device on there. But that's not for patient benefit, that's for our benefit. And I think there is a use for it perhaps in resource-restrained systems, places where you only have 2 people. That's not where most of these devices are being adopted, though. And I think you can make a case that in ongoing resuscitation, after some period of really good manual compression, say 15 minutes, that it has benefit, potential benefit, to implement it in a controlled fashion. But as our friends in Austin have demonstrated, it also has the potential to be harmful. And they did it right there. So what I'm worrying about is that we're running headlong into repeating the mistakes we've made in the past. The mistakes, yes, with mechanical CPR, but also with MAST, with high-dose epi, with steroids for spinal injury, with backboards, with calcium indiscriminately in cardiac arrest. It's a very long list of things we knew worked right up until we adequately studied them and found that they didn't. I worry we're adopting promising technology that is not proven and may ultimately prove to have no benefit and will certainly cost an awful lot of money. So for this reason, I think we must have well-done randomized controlled trials that are free from commercial bias that show clear benefit before I feel comfortable adopting it and before I can recommend widespread adoption. We definitely need that before any organization puts out position statements saying this is the standard of care and should be widely adopted. I'm encouraged to learn on this last part, the need for RCTs. I'm encouraged to learn that there is at least one RCT being planned. So I went and I searched clinicaltrials.gov, great place to go. Now, first it shows a French before and after feasibility study called the Gravity trial that is apparently already done. They just completed enrollment of 126 patients in October of this year. Now, that's too early for them to have published, but it should be coming out soon. I'm excited to see this. But what I'm really excited about is to learn of the UK-based Cabaret trial. This is a university-funded trial, does not appear to be manufacturer-supported. And the proposed study is going to test the feasibility of a randomized controlled trial with the intention of conducting a full trial if it is feasible. That is really, really good. Until I see higher quality evidence with less risk of bias, I don't think the expense is justified given the risk. I truly hope to see this evidence bar met, but until I know this isn't just another pair of MAST pants, I can't adopt it, and I can't recommend anyone else adopt it either. As always, thank y'all for listening, and thank you for what you do every day for your patients and for your communities and for our profession. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.